Welcome to Imperfect Heart, a place for you to join me, Jeff Holden, in conversations, discussions, and dialogue about our hearts and the impact myocardial bridges have on them. We'll talk with healthcare professionals, those in related fields that support our condition, and others just like us with stories of their myocardial bridge experiences. It's my intention for this content to inform, educate, entertain, and even motivate or inspire you in your personal journey on dealing with a myocardial bridge. Most importantly is to have you leave each episode with hope, knowing you're not alone and that what you're experiencing is real. This episode continues a dialogue that has been a topic of conversation in many circles regarding the process of unroofing a bridged artery. The question is, should a bypass be done as well as the unroofing procedure of the affected artery? I'm speaking with Dr. Christopher Kwon, a veteran cardiothoracic surgeon who has spent more than 2 decades treating complex heart conditions, most recently, a growing number of patients with symptomatic myocardial bridges. He's worked in major market healthcare systems around the country, but has chosen to exercise his craft today in a small market hospital in Lake Havasu, Arizona. How fortunate that those in this community have a doctor who not only recognizes myocardial bridges as symptomatic, but he's also the surgeon who will do the procedure to correct the condition. We now have somebody who may be able to help those in or around the Lake Havasu area, Greater Arizona, or even Las Vegas. Those are all reasonable driving options. In this conversation, Dr. Kwon shares how this condition found him and how his particular approach, combining unroofing with a bypass procedure, has been effective. We unpack everything from sternotomy fears and competitive flow concerns to the importance of patient advocacy, proper diagnosis, and insurance. You may be surprised by some of this conversation as there are some distinct differences to what you might normally hear on the program. Dr. Kwon is certainly giving us all something to include in our conversation and questions when we speak with primary care physicians, cardiologists, and surgeons. Dr. Kwon, welcome to Imperfect Heart.
Thank you very much for having me.
Let's start with what led you to become a cardiac surgeon in the first place. What was it?
Well, it was a desire to help people and to do something that was technically challenging. And But surprisingly, it wasn't my first choice. I originally started wanting to be an electrical engineer, and then decided that going into medicine was something where I could have a greater impact. And so, rather than helping uh, hundreds and thousands of people by designing some sort of electrical equipment, I decided to help one patient at a time, and I think that really has become my focus. And treating the heart was really just uh, because it was something that was more detailed and complex, and we deal with a lot of sick patients, and so through my medical and surgical training, that is really where I ended up, and it's been very rewarding through the years.
Well, interestingly enough, the heart is quite an electrical feat of engineering in itself, right?
That is correct. And if I think about it in retrospect, the field of electrophysiology, which has become uh, a huge field in cardiology and cardiac surgery, uh, would have melded nicely with my background. I think electrophysiology back in the day when I first went to med school and make the decision was not as big, and so I suppose if I had the forethought, my trajectory could have been a little different.
How long have you been practicing now?
I've been in practice now close to 21 years. That means after training, so I've been in the community practicing for that long, and mostly in Arizona. I started out in Phoenix, and then decided to come out to this rural community and start the program back in 2008. But that I have traveled a little bit and practiced on the East Coast where I grew up. So I've seen modes of practice all over the country.
Well, what a great fortune you are for the people in the rural part, Lake Havasu, from big city to bringing all that technology into a smaller hospital system. And I'm excited to talk about that because while you are a heart surgeon, you're also practicing in a variety of different heart procedures. And more often than not, and in our previous conversation, you were saying that sternotomy is the preferred way, which in many cases for our audience is the greater anxiety than the heart surgery. Tell us a little bit more about your detail and why sternotomy.
Well, that's correct. So most of heart surgery still is performed through the midline incision sternotomy. And I'd have to say that's still the safest approach in most cases. However, cardiac surgery has evolved through the decades, and many operations nowadays, including bypass surgery and valve surgery, are done through less invasive approaches and through small keyhole incisions. So we have also offer those types of operations here in Lake Havasu, but we try to, when speak to the patients, we try to demystify the whole concept of sternotomy. And I think patients fear sternotomy because of what they've seen on the internet or read in pictures, or prior family members who've had surgery decades ago or many years ago have seen. And we try to help them understand that the way that it's done currently and the way we repair the sternum after we've done the operation are done with additional techniques nowadays. So patients may have less pain, they're back to activity sooner, the wound healing is better, uh, and so there's less to fear after surgery than they might think. And most patients, after a sternotomy is done during their recovery, will let us know that it really doesn't hurt that much. And that's surprising the fact, given what it seems like it would be. And patients usually have more discomfort from the small drainage tubes and the vein harvest site when we do bypass for using vein conduit that needs to be harvested from the leg. So patients they become a little bit more comfortable with it once you explain to them the whole process and how things are actually done. Uh, Most patients fear it because uh, there's in colloquial speaking, patients have heard that we crack the chest, but we don't crack the chest. There are techniques for opening the chest and for closing the chest, and it's not to be feared if you understand the process and how we fix the sternum and how well patients heal and recover.
And going through sternotomy from your perspective is preferred because it gives you the access, correct?
So for most open heart operations, especially nowadays when we do complex operations and multiple procedures at once, the sternotomy is definitely the preferred approach. It's the safest. It allows us access to all the heart structures uh, and allows employing techniques that all heart surgeons are familiar with.
You do a variety of different procedures, and certainly bypass is one, and aortic valve replacement, and even more complex procedures. What is it that led you to address myocardial bridges? It's not that frequent that they present as symptomatic in the grand scheme of things.
Well, I have to credit the town and being in the right place at the right time with colleagues that also recognize the disease process. And I have to say, uh, this disease process is not one that sought out. It's one that found me.
Hmm.
And despite the fact that I've been in practice close to 21 years, I've seen more myocardial bridging in the last couple years in Lake Havasu City than I have prior to that. So I've had the opportunity and privilege to be able to treat multiple patients with this diagnosis. I work with a group of young cardiologists who understand the disease and realize that this could be what's causing the patient's symptoms. And after exhaustive diagnosis, discussion, and testing, we have moved forward with treatment of these patients, and we've had good results, and the patients have had good outcomes and have had symptom resolution.
Do you work on a beating heart or on a still heart?
We can do it either way. So we are able to do beating heart surgery and arrested or still heart surgery with the heart lung machine. So the procedure for myocardial bridging can be done either way. I think it's in the hands of the surgeon. The the situation with the patient, where the artery is, maybe it's very deep. So one situation may call for use of the heart lung machine and arresting the heart. Another situation may allow for an off pump technique and operating on a beating heart. So both techniques are appropriate. The surgeon can employ either technique. The outcome of the patient should be no different.
Let's take a step back just for a second with regard to the symptomatic part of it. Do you have any requirements for patients to have a provocative test, or how do you best identify the likelihood of the outcome before you go in to repair the bridge?
Well, first, they've had non invasive testing, and most patients have had some type of medical therapy with medications like calcium channel blockers. And obviously, they've had an angiogram that shows the phenomenon of bridging in one or more of the arteries. Uh, if they have failed other medical therapies, then they may undergo another angiogram to demonstrate and undergo some provocative testing. Sometimes it may be injection of medication to induce spasm
Mhm.
and reproduce symptoms. That can be done with acetylcholine, or it may involve some type of uh, induction of stress chemically, like with dobutamine, and measurement of a fractional flow through the artery to demonstrate physiologically that there is reduced flow during the spasm of the artery when the heart is beating, and you see that bridging in the artery. So provocative testing can be done. I don't think it's imperative that it's done if you believe that that is the diagnosis and the patient has had all other causes ruled out. But certainly it does lend additional strength to be able to recommend an operation to fix the problem.
And I think in our conversation prior, you had even mentioned if the patient's symptomatic, demonstratively symptomatic, clearly there's an issue. And
That's correct.
you've identified that bridge, so let's go in and take care of it. And this is the part I've been most excited to speak to you about because you're doing it a little bit differently than most. And that's that you address not only the bridge, but you are bypassing the artery as well. And is that only the LAD or is it if there are other bridged arteries, do you do the same?
So most frequently, I've seen the LAD as the primary culprit with bridging. So it has been bypassed with the LA to the LAD. I call it a belts and suspenders approach. I like to have a backup plan. So if one is going to have a relatively complex operation, it's heart surgery to fix bridging. I'm going to cut the muscle fibers to uh, relieve the bridging phenomenon, but there is a chance of recurrence with scar tissue. There's always the chance that you may miss a few muscle fibers. And so, in addition to doing the lysis of the bridge or cutting the muscle fibers, I also bypass the artery. And in cases where it involves the LAD, the left internal mammary artery is harvested and bypassed to the downstream part of the LAD. And that way, if one fails, the other will work. And I feel like that way I've ensured that my patient is going to have relief of symptoms.
Is there, and maybe let me rephrase this a little bit differently. We see in our Facebook group conversations, people concerned or people have had competitive flow issues. Maybe you could tell us a little bit about that. First of all, what does it really mean from your perspective? And secondly, does that bypass graft hold up over time? Let's say you're doing a patient that maybe is in their 30s, 40s, even 50s.
Well, the if the bypass graft is the left internal mammary artery and you have competitive flow through the native artery, the LAD, then there is a chance that the bypass graft will occlude over time. In the case of the left internal mammary artery, many surgeons do believe that it may not occlude completely, and what would happen is that it would become it may become constricted and become smaller. But if any disease develops in the LAD over time, the left internal mammary artery is thought to increase back in size and start to work again in the future. That may not happen with a vein. If a vein has competitive flow and is bypassed to an artery that has had bridging treated, then the vein may occlude, and once the vein occludes, that's it. It's not going to come back.
Mhm.
So with my patient population, at least the 4 patients I've treated in the past 2 years, I've every case has been bypassed with a left internal mammary artery or the lima. And so my expectation with those grafts is if they do see competitive flow in the native coronary artery, the LAD, then the flow through the left internal mammary artery may decrease, but over time, if disease develops or there's recurrence in the LAD, then the left internal mammary artery should hopefully plump back up and start to function as it should.
That's great to hear, and I think that's gonna relieve some of the questions and concerns that people have about it because that's an atypical procedure for the most part today, and I do know that from conversations with some of our interventional cardiologists, it is becoming a topic of conversation in the unroofing procedure. Should we not just automatically do the bypass as well to be safe? And
Well, it is an accepted therapy. So when one has bridging, one can employ either cutting the muscle fibers or lysis of the bridge or bypass to the artery. I just choose to do both.
yeah, and I think most people would prefer just because of the security of knowing they had both done, and we are
Correct.
hearing now cases of patients that have had just the bypass procedure. We interviewed somebody just a few episodes ago, and she's fine.
Yes.
In terms of the actual procedure itself, we know that the LAD is the primary, it's typically the one that's addressed. What about situations where maybe somebody didn't completely unroof that artery, did the bypass, but there's another artery that was bridged as well? What might be the outcome in that situation, or is there a way that you can address that while you're in there and recognize it?
I think if there is bridging of multiple arteries, then we should make an effort to treat all the arteries. Uh, if it is Now the heart has 3 primary branches. If the bridging is in one of those primary branches, I think I would strongly advocate treating all the primary branches. If there is bridging in a smaller side branch, those smaller side branches may not be as important in uh, the overall treatment of the patient as far as preventing a major heart attack or uh, saving myocardium or heart muscle. It may still be important in the sense that they may have angina. Uh, so I suppose if the side branch was big enough, I wouldn't necessarily bypass it, but I perhaps make an effort to lyse the myocardial bridge so that it may relieve the angina in a small branch that might be causing it.
Is that even a possibility? If you bypass the LAD, is there an opportunity in some situations where you might even bypass one of the secondaries?
Absolutely. When we do bypass surgery and other situations when we patients have multivessel coronary disease, we may be bypassing three, four, five, six targets. And if all these vessels have blockages that would restrict flow and the branches are big enough, then we may bypass them. So just because you only have three primary territories, uh, a triple bypass is not done uh, solely because you have only three primary vessels. Each of those primary vessels oftentimes has large branches that come off of them that also have disease and also may be important in the amount of heart muscle that they do supply or myocardium that they supply. So oftentimes you will hear patients getting, five, six, and seven bypasses, and you think to yourself, well, where is it all going? Some patients have more vessels than others. It's because some patients have bigger targets and larger side branches than others, and the blockages may not lend themselves to retrograde flow from the other bypass grafts. So you have to restore flow to all the tributaries as well. So
And is that also done with a Lima process?
typically the Lima only goes to the LAD, and I would say in the vast majority of cases, the Lima is always placed to the LAD. In the minority of cases, we may sometimes put the Lima to other branches if the native LAD is a very small or heavily diseased target that may not necessarily fare well with any bypass graft. So you would save the Lima for other target vessels if the native LAD is not a good target vessel.
Is there ever a situation where you wouldn't consider doing the unroofing procedure?
You mean in lieu of just doing bypass? Or,
No, I mean the whole procedure. So somebody comes through, they're symptomatic, they're clearly hemodynamically challenged with flow. What might be a situation where you say, this particular patient, this situation maybe isn't going to be best suited for, the
well,
entire
certainly
unroofing
you
procedure
have to
with
be
the
a
bypass?
candidate for heart surgery, whether it's done through a minimally invasive or less invasive approach or through a sternotomy approach. You have to be a candidate that will tolerate and be able to be recovered and rehabbed after the procedure. And if you're not, then
Mhm.
the unroofing procedure cannot be done. But if you're a good surgical candidate, then there's no reason why an unroofing couldn't be done and a bypass. I will stress that I do believe that unroofing of the bridge and bypass would be the preferred treatments, not stenting.
Yeah, thank you for clarifying that. And now I'm gonna ask you a question that's a little bit more difficult because it's a peer-based question. We have so many people who get to their cardiologist and they get dismissed. And you certainly are a believer, you understand, you repair the condition. What might you say to some of those cardiologists who are I mean, they're on the fence of this thing. They say, I'm not quite sure. I've never been trained that these are symptomatic. Maybe that patient is trying to demonstrate, here's a doctor who understands. What might you say to those who are stuck in that
Well,
borderline
I
dismissal
think
still?
that uh, shows like yours, uh, podcasts and other educational materials are great because it brings knowledge to the community and to practitioners. So I think that's one thing. The other is I and other uh, physicians who believe in the entity and the treatment of myocardial bridging um, would be happy to have a conversation with physicians and patients that may believe or they have the problem or who have doubts on whether this could be what's causing the symptom, and would encourage people to at least have a conversation. And uh, even if you're a physician, and nowadays, uh, it's a consumer's market, right? Medicine is a service that we provide, and the patient is at the center. And if the patient um, needs additional information, they should feel confident in being able to ask for a second opinion. Uh, and so they can be referred to a cardiologist or a surgeon who may have uh, belief in the disease process and have treated patients, and may be able to have additional conversations with that patient without making it awkward for the original physician, who may be the person taking care of the patient, and therefore thereby giving at least the patient the opportunity to have a conversation with someone that might understand the disease process and believe that they might be having these symptoms.
I love what you just said, and that's such a key point because part of it is self-advocacy. You have to know and you have to be able to move past just one dismissal, but the other part is giving at least credibility to that particular patient's doctor to say, "Hey, let's give you the opportunity for a second opinion," to maybe where they can be persuaded or understand differently to move that patient along
That's
for proper
correct, and
care.
I think in today's medicine, we have to be open-minded as physicians to allow patients to have other opinions, to be sure that they feel comfortable that they're receiving all the attention and knowledge and education that they can, because you don't always get everything you need just by looking things up on the internet. Fortunately, you have good informational podcasts and other patient-centered programming that I think offer good information and at least put knowledgeable people in touch with uh, the patients and other uh, providers to kind of spread the knowledge and do good things as you were doing.
I wanna ask you a question I ask of all the doctors that we've had on the program. Do you believe a myocardial bridge could be the cause of sudden
That's a
cardiac
tough
death?
one. As with any other coronary disease, if I suppose if it is proximal enough in one of the important coronary arteries, one of the three primary vessels, if it's a very proximal bridge and it causes an arrhythmia with a ventricular tachycardia or ventricular fibrillation, then it is plausible that it could cause sudden cardiac death.
One of the things that we get a lot from the patients, the people that I talk with, is as they find the doctors that they're interested in, and many will travel anywhere to get to care. And we have people coming from the East Coast to go to Stanford, which is a institution doing a lot of research in myocardial bridges. We have people from the Midwest traveling to University of Pittsburgh Medical Center or Cleveland Clinic just because they like the way that doctor presented himself. They learn a little bit about it in the episodes because we asked this question I'm about to ask you. You have a tremendous amount of weight on your shoulders when you're holding somebody's heart in your hand. And that truly is a life and death situation. When the day's over, what is it you do to relax and just get away from it
Well,
all a little
that's
bit?
I suppose everybody's got something different, but I we live in a small town. We lead quiet lives, and I think I spend time with my family and my wife and the dogs. I got to mention the dogs, and that really kind of recenters one after a rough day or an intense day. Uh, and and I don't know if you've seen Lake Havasu City, but the scenery is beautiful and things are quiet and most nights are clear and you can see the stars. And I think those things recenter people. uh, and so family, uh, environment, pets, and um, spending time on the water and the lake. I think those things are all what we do to try to stay centered and stress free. Yeah.
I hear my audience right now going, "What kind of dogs? You gotta ask them
So
what kind of
we
dogs,"
do. We
because
have two
people love their
standard
animals, as
poodles.
you know.
One of them is 45 pounds. The other one is 100 pounds. They're both
Oh
reds,
my gosh,
and
that's
one's
a big
from
dog.
Pennsylvania. The other one's from Colorado, and they really keep us healthy and emotionally healthy. The entire family.
Well, you have 150 pounds on 2 leashes when you're walking those dogs.
No,
That's
especially
nothing
when
to
my
sneeze at.
wife
You
is
have to be
walking them,
careful.
and she's only 95 pounds, and she likes to walk the big one. So,
Oh, how fun. Well, Doctor Kwan, what would be the best way for an interested party to get a hold of you, and help them either make the decision or decide if it's, a hospital system they wanna come
well, we are
to be
here
treated?
in Lake Havasu City at Havasu Regional Medical Center, which is part of the LifePoint healthcare system in the western part of Arizona. It's a beautiful area to come and uh, convalesce if you'd like to. Um, you can contact my office through the number that you may provide from my office, and either email or LinkedIn, and I can provide that information for you offline.
Okay, perfect, and I will put that in the show notes too, so people can just go down, click,
Okay.
and have access. Thank you so much for your time, your insight, your knowledge, your unique approach. And before we exit, there was one other thing I wanted to ask you because you brought it up in our conversation prior, and that was the insurance element of it all. Many people will go in and they go in to address the myocardial bridge and they find out, nah, we don't do that with this particular policy or this particular plan. But in our conversation, you said because this is a bypass surgery, it gets a different
So
look.
that was an interesting thing when you brought that up with me because I hadn't quite thought about that before. But when you had mentioned it, it did occur to me that there is likely not a diagnostic code or a procedure code that insurance companies may easily understand or authorize when one wants to do a lysis of myocardial bridge procedure. It will get coded as just a general cardiac procedure, and so the proper coding of these procedures will have impact on whether patients may get authorization by insurance for the surgeon to be able to provide the care. And nowadays, because many patients who have Medicare are on commercial insurance because it is a managed Medicare plan, we may have trouble getting authorization for certain types of procedures. I realized that when you had mentioned that issue, that because I had made the conscious choice to treat patients with both the bypass and the bridging, they the authorization process is for bypass surgery. And so as far as I know, we've not had any problems getting insurance authorization or Medicare to approve the procedure for these patients. So when they come to surgery, they get a bypass and they get their, you know, lysis of myocardial bridge. And I've not even had to have a provider to provider phone call with the insurance company to advocate for authorization. So it's been an easy process. I think if one authorizes for bypass surgery in addition to the lysis of myocardial bridge, then there should be hopefully less difficulty in on the insurance aspect and authorization part of getting the procedure done, so that you can take care of the patient.
And I think a lot of people are going to appreciate that because it'll change the conversation they have with their doctor as well, and their surgeon as they get to that point in the process to be able to say, if we look at this a little bit differently and we're looking at it as a bypass procedure with the unroofing procedure versus the unroofing procedure, no bypass or maybe a secondary conversation of a bypass they won't know until they get in. It
It
changes the
may, and it
dynamic
may help
considerably.
patients kind of get through the process a little bit more easily, because we all know how difficult sometimes it can be with the authorization process. It has gotten more difficult through the years, and so anything we can do to try to expedite things for the patient, make it easy, I think, is a good thing.
And I'm going to ask for those patients who go through this process, please let me know too, because it will be helpful for us to identify for those that we don't have on the program or share in other ways
Sure.
for us to have that conversation off program and give them some hope that they can get taken care of in their regional or local community as opposed to having to travel halfway across the country, in some cases to
Yeah.
Greece or somewhere else. And we have
Sure.
patients globally too, where they can bring this up because maybe that doctor's more familiar with the bypass procedure and says, "Okay, well, I get
Yeah.
that. Let's at least go there."
Certainly.
Wonderful. Well, Dr. Kwon, thank you so much. This has been incredibly, incredibly valuable, and I know a lot of people are going to open their eyes a little bit to the conversation of the bypass with the unroofing procedure. And I suspect it's gonna generate, a different conversation around this episode because it's the first time that we've had this discussion this way. So as a catalyst, I thank you for that as well. And from the bottom of my imperfect heart, I appreciate what you're doing for us.
Well, I appreciate being on your show and being asked to participate in this endeavor. And I think you're doing a great thing. And I've enjoyed our conversation and hope we can talk more in the future.
Wonderful. And take care of those dogs. Don't let them drag your wife down the street at any point.
They're good dogs. We enjoy them. Thank you very much. We will.
Thank you, Dr. Kwan. Thank you for listening to Imperfect Heart. It's my hope that this information helped in some way to improve your situation or will help you better understand this condition. More importantly, that it gives you hope through stories that there is help and you most certainly are not alone. If you've been diagnosed with a myocardial bridge, please be sure to join the private Facebook group, Myocardial Bridge Support Group. For more information about our program or to reach me directly, visit the website, myimperfectheart.com. If you like what you heard today, please give a positive review, thumbs up, high five, or whatever your app likes. And be sure to share with everyone important to you so they understand what it is you're dealing with. Please subscribe as well. Welcome each day with gratitude and positivity. The views and opinions expressed in this program are solely those of the host and the guest and are not intended to provide, nor are they a suitable substitute for, professional care by a doctor, therapist, mental health professional, or other qualified medical professional. Imperfect Heart is a production of Hear Me Now Studio.